Hello everyone, good evening. Today under oncology we have to discuss about disorders of hemopoietic system. So with this presentation which is available on Moodle for your reference, we will discuss about disorders of hemopoietic system. First of all, hemopoietic system is the body system of organs and tissues, primarily the bone marrow, spleen, tonsils and lymph nodes involved in the production of blood. Again, what is hemopoietic system? The body system of organs and tissues, primarily the bone marrow, spleen, tonsils and lymph nodes involved in the production of blood. Here you can see the diagram of hemopoiesis. You can see hemocytoblast, how it differentiates and becomes into different blood cells. Disorders of the hemopoietic system mainly divides into three main disorders. First one, MDS or myelodysplastic syndrome. Then we have leukemias. Then we have lymphomas. Under lymphomas mainly we have Hodgkin's, non-Hodgkin's, multiple myeloma. Let's go according to the presentation. Predisposing elements. What are the predisposing elements for hemopoietic system disorders? First, it could be heritable or genetical. Heritable means genetic disorders including Down syndrome, congenital neutropenias, Fanconi's anemia or Fanconi's anemia, ataxia. Acquired reasons are mutagen exposure or exposure to a mutant, and that may be hemopoietic cell plants, environmental exposures, aplastic anemia, polycythemia vera. Let's start with the first type of disorder of hemopoietic system, that is myelodysplastic syndrome, or in short form we say MDS. Myelodysplastic syndrome comprises a group of malignant stem cell disorders characterized by ineffective blood cell production and variable risk of transformation to acute leukemia. That means in MDS there is a higher chance of this transferring to a acute leukemia. Clinical presentation could be non-specific and varied. Varied means that it may depends on the situation. Mostly asymptomatic and diagnosis found on labs when patient presented with other symptoms: fatigue, dizziness, weakness and lethargy. Patients don't feel well. Less commonly we have bleeding and bruising. Fever and weight loss is uncommon in this type of a disease. Neutropenia and granulocyte dysfunction is principal cause of death in myelodysplastic syndrome. What is neutropenia? Penia means when the count goes down or when it's less than normal, we call that condition penia. I am sure you have heard the word leukopenia, thrombocytopenia, pancytopenia, neutropenia. That means the count goes lower. Physical findings of patients with myelodysplastic syndrome or MDS are 60% of them could be pale. 25-26% may present with petechia and or petechiae or purpura. What is purpura? That is skin discoloration or petechia. We can see, we can simply say the internal bleeding which reflects the skin or reddish color skin discoloration. It looks like a patch. Lymphadenopathy or enlargement of lymph. cutaneous manifestations or skin manifestations like acute febrile neutrophilic dermatosis and myeloid sarcoma. Lab findings. Bone marrow and blood changes may be variable. Chromosomal abnormalities are associated as well. Anemia almost always present with low retic response. Pancytopenia in up to 50% of cases. What is pancytopenia? That means the less counts of entire blood cells. All the blood cell count becomes less than normal. We call that condition pancytopenia. Less than 5% of cases have isolated neutropenia or thrombocytopenia. Then the next type of disorder, which comes the next disorder of Haemopietic system, that is leukemia. Leukemia associated with development of the blood cancer, or we call it a type of a blood cancer. What are the things that are associated with the development of leukemia? Chemical agents, chemotherapeutic agents, virus, radiation, and maybe immunologic deficiencies. When we classify leukemia, we have mainly 4 types of leukemias. First one is acute lymphocytic leukemia or ALL. Then acute myelogenous leukemia, AML, that is also called acute non-lymphoblastic leukemia, ANLL. Then we have chronic myelogenous leukemia, CML, and chronic lymphocytic leukemia, CLL. Again, what are the main 4 types of leukemias? First of all, we have acute and chronic leukemia. In acute leukemia, we have ALL, AML, and in chronic leukemia, we have CML and CLL. Again, this is very much important for you to remember. So, acute lymphocytic, acute myelogenous, or we can say acute myeloid, or chronic myelogenous, or we can say chronic myeloid, and chronic lymphocytic leukemia. Let's start with AML, or acute myeloid or myelogenous leukemia. This leukemia characterized by proliferation of myeloid tissue as of the bone marrow and spleen, and abnormal increase in the number of granulocytes, myelocytes, and myeloblasts in the circulating blood. And AML accounts for 1/4 of all leukemias. And 85% of the acute leukemias in adults are acute myeloid leukemias. The rest 15% is acute lymphocytic leukemia. And this AML has an abrupt, dramatic onset. Like all of a sudden, it occurs and it becomes worse. Serious infections, abnormal bleeding that can be there. Uncontrolled proliferation of myeloblasts. Hyperplasia of bone marrow and spleen. What is hyperplasia? What is hypertrophy? Hypertrophy means when there's increase of cell mass or increase of cell size. When someone practices in gym or when they do this bodybuilding, their muscles undergo hypertrophy that increases in size. The cell number remains the same. But in hyperplasia, what happens? The cell number increases. That's why we say uncontrolled proliferation of myeloblast. Hyperplasia of bone marrow and spleen. Bone marrow and spleen, the cell number increases, not the size. Leukemic infiltration by the blastic cells of marrow, spleen, liver, kidney, and rarely lymphatic nodes. Infiltration of mucouses and serosal membranes by the blastic cells. Leukemic meningitis, leukemic pneumonitis, leukemic gastritis can occur. What happens here? Infiltration. These mucus layers are infiltrated by the blastic cells, the uncontrollably growing blastic cells. Hemorrhagic diathesis, bleeding, ulcerous necrotic complications and sepsis may occur. Then again, leukemic infiltration of kidneys, bone marrow and spleen also can happen. We can take bone marrow biopsy to identify this kind of a disease. Here you can see one example of a bone marrow biopsy. How does it look like? The specimen looks like of AML or acute myeloid or myelogenous leukemia. We have diffuse immature myeloid hyperplasia with early maturation. Here these are matured early and that's not well differentiated. Matured early means that not well differentiated. And we have immature myeloid hyperplasia. Here the number has been increased, so we call it hyperplasia, not hypertrophy. And here in this diagram you can see, or this photogram you can see, blood smear of acute myeloid leukemia. Look, immature myeloblasts partly with lymphoid appearance. Here they are appearing partly as lymphoids. Then the next type, acute lymphocytic leukemia. Signs and symptoms may occur abruptly. That means signs and symptoms, they occur all of a sudden. What are the main signs and symptoms? Those are fever and bleeding, insidious with progressive, weakness and fatigue. Central nervous system manifestations could be there. Lymphoblast infiltrate of marrow, lymphatic nodes, thymus gland, spleen, intestine and kidneys. Can you remember in myeloblastic in myeloid leukemia, those things, they infiltrate the mucus and serous membrane. Here lymphoblast infiltrate again marrow, lymph nodes, thymus gland, spleen, intestine and kidneys. Thymomegaly or enlargement of thymus gland, splenomegaly, enlargement of spleen can occur. Complications and cause of death. What is the main complication? Hemorrhage to vital organs, bleeding from vital organs like brain. Ulcerative, necrotic and septic complications like sepsis can occur. Then we have chronic myelogenous leukemia. Here in first paragraph in your left side, you can see blood smear showing increased number of metamyelocytes and myelocytes. Here blood marrow smear, mild increase in myelocytes and myeloblasts and decreased erythropoiesis. Then CML, chronic myeloid leukemia or myelogenous leukemia. What happens here? Excessive development of mature neoplastic granulocytes in the bone marrow move to peripheral blood in massive numbers, ultimately infiltrate the liver and spleen. What happens? Excessive development of mature neoplastic granulocytes, and that move to peripheral blood in massive numbers and infiltrate liver and spleen. Here there's one chromosome which acts as a genetic marker for CML, and that is Philadelphia chromosome. The chromosome abnormality that causes chronic myeloid leukemia. That's a genetic marker. Chronic stable phase followed by acute and aggressive or blastic phase. Pay attention on this chromosome, Philadelphia chromosome. CML here in these photographs. On left side you can see myelomonocytic variant of chronic myelogenous leukemia, immature cells, and bone marrow smear of chronic myelogenous leukemia or CML, increased number of monocytoid cells. Then we have CLL or chronic lymphocytic leukemia. Here what happens? Leukemic infiltration takes place in marrow, lymphatic nodes, spleen and liver. Blastic crises are possible. Marrow is red or marrow becomes red. Splenomegaly occurs. Liver and kidney are increased in size or liver and kidney are enlarged. Hepatomegaly, hemorrhages and pneumonia. In CLL, production and accumulation of functionally inactive but long-lived mature appearing lymphocytes. Pay attention, production and accumulation of functionally inactive. They are inactive functionally but they have a long life, mature appearing lymphocyte. And we have B cell involvement here. Lymph node enlargement is noticeable throughout the body. That means throughout the body lymph nodes are enlarged, and that's a sign of what? Increased incidence of infection, that we all know. Then in CLL, what are the complications that we have to pay attention? Early stage complications are very rare in CLL, may develop as the disease advances. Pain, paralysis from enlarged lymph nodes may causing pressure. What are the complications? May develop as disease increases or disease advances. Pain, paralysis from enlarged lymph nodes causing pressure can occur. Here you can see how the bone marrow has been red in color from here to here. Then we have lymphadenomas. What are the lymphadenomas? Regional tumorous diseases of haemopietic and lymphatic tissue. Lymphomas include lymphosarcoma, Zere's illness, Hodgkin's illness, non-Hodgkin's illness, and multiple myeloma. This is how a lymphosarcoma looks like. You can refer to these slides once you get the presentation. Then we have NHL or non-Hodgkin lymphoma. Lymphoplasmacytoid non-Hodgkin lymphoma show a mix of lymphocytes, plasmacytoid and occasional immunoblast. And on the right hand side you have follicular non-Hodgkin lymphoma showing nodular, partly follicular structure with mixed small and large cell population. Here also follicular center cell lymphoma on left side, and on right side we have large cell immunoblastic non-Hodgkin lymphoma. Burkitt type non-Hodgkin lymphoma. Here the classical Burkitt lymphoma showing densely packed lymphoblast with scattered histocytes containing nuclear debris. We call that the starry sky pattern. From an arrow they have showed you this starry sky pattern, sky looks like a sky full of stars. Infiltration of maxilla. Here, can you see? Infiltration of maxillary bone in this area has happened. That's a sign of Burkitt type lymphoma. Infiltration of femur bone marrow, and that is immunoblastic. Can you see? Here's the difference of femur bone. And again, the non-Hodgkin lymphomas, you can see infiltration of stomach and spleen. Stomach and spleen. This is how it looks like in a gross view. Then we have Hodgkin's lymphoma. We have 4 variants of Hodgkin's lymphoma. Variant 1 is prevail of lymphoid tissue. Variant 2 with nodular sclerosis. Variant 3 mixed cell Hodgkin's disease. Variant 4 with inhibition of lymphoid tissue. You may wonder, what is the main difference between Hodgkin and non-Hodgkin lymphomas? That depends on a presence of a small cell that we call Reed-Sternberg cell. If the Reed-Sternberg cell is present or cells are present, we call that's a Hodgkin lymphoma. If the Reed-Sternberg cells are not present, we can call it a non-Hodgkin lymphoma. Here in this diagram or in this photograph, you can see lymphogranulomatosis in Hodgkin's lymphoma. How the lymphogranulomatosis has occurred in such an tissue. Again, in Hodgkin's disease, here you can see the gross infiltration of spleen, gross infiltration of spine. Here, hope that is clear with you. Treatment and nursing interventions in disorders of Haemopietic system. Leukemia, the clinical manifestations. We have to relate to problems caused by bone marrow failure. Bone marrow failure occurs by overcrowding by abnormal cells. Abnormal cells are become overcrowded. Inadequate production of normal marrow elements. Anemia, thrombocytopenia, decreased number and function of WBC or white blood cells. Then the problems caused by leukemic cell infiltrate to patient's organs. When the leukemic cells are infiltrated to patient organs, there might be some other problems like splenomegaly, hepatomegaly, lymphadenopathy, bone pain, meningeal irritation, oral lesions. Diagnostic studies. How to diagnose leukemia? We have to do peripheral blood evaluation. Complete blood count and blood smear will do, and bone marrow evaluation. Bone marrow biopsy may help to identify cell subtype and stage. Morphologic, histochemical, immunologic and cytogenic methods we can use. Collaborative care of leukemia. The goal is to attain remission when there is no longer evidence of cancer cells in the body. Chemotherapeutic treatments we can do. In induction of therapy, attempt to induce or bring remission. Seeks to destroy leukemic cells in the tissue, peripheral blood and bone marrow. Patient may become critically ill. We have to provide psychological support as well. That is very much important in the case of a cancer patient. What is remission? Abnormal, immature white cells or blasts can no longer be detected in blood or bone marrow, and normal bone marrow has developed again. That we call remission. When there is no abnormal or immature blood cells and the normal bone marrow has developed again, we call that remission. But, however, the second point, even remission is achieved, there may still a very small number of abnormal lymphoblasts left. To destroy these, your doctor may prescribe maintenance or continuation chemotherapy, which may last for several years. Yes, blood tests can find particular protein present on the surface of the leukemia cells, can show if any leukemia cells are still present in the body. I think you understood this slide. Then chemotherapeutic treatment, intensification therapy. In intensification therapy, we have to pay attention to high dose therapy, which may be given after induction therapy, and the doses of the drugs. Then we have another type, consolidation therapy. We can do consolidation therapy only once we achieve remission or when there is no visible or detectable cancer cells. Purpose is to eliminate remaining leukemic cells that not be evident. And we have maintenance therapy, which consists of lower doses of the same drug to maintain the condition. Then we have the combined chemotherapy that comes under chemotherapy regimens. That's one of the mainstay treatments. Three purposes of this combined chemotherapy: to decrease the drug resistance, to decrease the drug toxicity to the patient, to interrupt cell growth at multiple points of the cell cycle. Then there's another option for leukemia, that is bone marrow and stem cell transplantation. Goal: to totally eliminate leukemic cells from the body using combination of chemotherapy with or without total body irradiation. That eradicates patients' Haemopietic stem cells. Again, that eradicates patients' Haemopietic or Hematopoietic stem cells, replaced with HLA match antigen. HLA stands for human leukocyte antigen. So, this kind of bone marrow can be taken from a sibling or brother or a sister, any person who shares at least one of the same parents, or by a volunteer or identical twin, or patient's own stem cell can be removed before. Nursing management in patients with leukemia. Overall goal is to understand and cooperate with the treatment plan, experience minimal side effects and complication of disease and treatment, and feel hopeful and supported during the period of treatment, relapse and remission. Nurse should be able to give some hope to the patient to make him feel hopeful. And many physical and psychological needs are there to be fulfilled. When patient cracks that he has leukemia, that evokes great fear. The patient's family also may need help. Balance demanding technical needs with humanistic and caring approach is very much important as a nurse. The management planning include the knowledge of disease and treatment can have a more positive outlook and improve quality of life. We have to empower patient, and nurses face special challenges when meeting intense psychological or psychosocial needs of a patient with leukemia. As nurses, we should be able to manage these points. Ongoing care is necessary to monitor for signs and symptoms of disease control or relapse. Of course, ongoing care of a nurse is very much important. Teach patient and significant others diligence of disease management, need for follow-up care, and when to seek the medical attention. That you have to teach and educate patient and patient's party. The supportive care. Then the main goals of rehabilitation, in rehabilitation paths, to manage physical, psychosocial, social, spiritual and delayed after effects of this patient. We can introduce patient to support groups and recreational groups. Evaluation effectively with diagnosis, treatment regimen and prognosis. Attaining and maintaining adequate nutrition of the patient. Experience, make sure to experience there are no complications. You make sure there are no complications to experience and to feel comfortable and to support the patient. That's it about today's presentation. We hope that you understood the material, the module, and we hope to see you soon at our premises. We hope to discuss more about these topics once you are present over there. And we wish all of you to be safe and thank you very much for your time.